Now a pleasure to welcome our next speaker, Dr. Matt Gardiner. He's an assistant professor of ophthalmology, and among the titles he holds are the director of the Mass Eye and Ear Emergency Department and the associate chief for clinical affairs. In these roles, he's been uniquely poised to see firsthand the kinds of effects that COVID-19 has had on clinical care, and he will discuss what has changed in healthcare during this crisis and what is likely to continue going forward.
So today I'm going to talk about our approach to COVID-19 at Mass Eye and Ear. So in January 2020, everything was rosy. We had lots of patients, lots of visits, and plenty of surgeries, and blue skies as far as we could see. But then COVID-19 came, and as they say, the Lord giveth and the Lord taketh away. So our numbers dropped significantly. We only had, in the month of April, 2,000, almost 3,000 visits. Surgeries dropped to 200. So that's from the 14,000 and 1,000 before. So probably about an 80% drop. Very happy about this. So our main principles in responding to this were to protect the staff and protect the patients to make sure that nobody got sick. Of course, we wanted to stay open to make sure we could serve our population. Our key safety measures that we employed were screening, both first by phone, so MSAs calling patients at home to make sure that those who are at risk didn't come in, and at the entrance asking questions at our new beautiful revolving doors, and then at check-in when the patients came up to the clinics, the MSAs were asking similar questions. Reduced our patient numbers, seeing only urgent or emergent patients, and we made sure we had enough personal protective equipment in terms of masks, gowns, gloves, and face shields. In the clinics, we canceled all routine visits, down by 75 to 80%. Some of those patients were rescheduled, but some actually just didn't even want to come in because they were too afraid. At the same time, though, we maintained our staffing. We had one doc per specialty clinic per day so that everybody had access to the subspecialty consult services, even though otherwise the clinics were poorly populated. We kept all our satellites open to support the community and devised some new protocols for cleaning. We had extensive room cleaning done after each patient. We had techs doing the workup in the, and we had the patients getting workups in the MD rooms instead of being transferred around from the tech rooms to the waiting room back to the MD room to minimize patient movement. And we spread out the appointments for space in terms of the seating. Our main goals in the emergency room were to, of course, stay open and protect the EW from any sudden surges of patients. We were concerned about two particular types of patients coming in. Many practices completely shuttered, closed their doors, furloughed everybody, and then sent their patients to us saying, we're closed, go to Mass Eye and Ear. But then a second group of patients came from practices that were still open, have the capacity to deal with the COVID suspect patients. In the EW, we had physical changes and people changes. We put doors on the rooms. We took down the old curtains in the EW. We spread out the seating in the waiting room, made sure we got enough PPE. In terms of the people, we staggered the nursing and the ancillary staff. We had half the residents at home and half at work, so then everybody got sick at once. We pulled the residents from some rotations to help cover, but we still covered all of the emergency departments across partners in terms of ophthalmology. We converted our 10th floor into a COVID unit, so taking care of patients who were discharged from MGH, but weren't well enough to go home. We took care of these patients with a lot of our resident volunteers, and everybody had a good time. So now we're in the recovery stage. So we've rescheduled thousands of clinic visits. We have to work on rescheduling 4,000 OR cases between ENT and ophthalmology, but at the same time, we have to follow state guidelines. So we have to go according to the stages that the state dictates. We can't just do it all at once. So essentially, we're adjusting to the new normal. Then walks telemedicine, which previously had been sort of a novelty, but now it's become one of our main modalities for patient care delivery. We can do this via telephone, video, or hybrid. And Ankur Shah will go into some of this later. Our ophthalmology virtual visits have increased dramatically. So in March, we had 148, and it's increased to a regular 500 or more per month now. So the big game changer for us was Epic integrated visits. So before, you had to have a separate Zoom account. The patient had to have a Zoom account, 2 applications open. Now this is much easier because it's all seamlessly integrated. So you can have these virtual patients mixed in with your regular patients. And here's what that looks like. We have our doctor and our patient. There's a waiting room. And all this is very seamless and easy, safe, without the risk of Zoom bombing. Now, hybrid visits are a little bit different In this process, the patient arrives at the office, the tech does a minimal workup in terms of vision and pressure, and then tech does specialized testing. They'll do OCT or visual field. The patient then departs, and the doc will then video call patients at home later, assess the patient data, and the patient together with the physician can review the images in detail. And here's what this looks like. This is courtesy of John Miller, who's been doing a lot of these visits. So here you have your doctor and your patient, and they can closely one-on-one review these images looking for any abnormalities. The benefits of this is that it allows for seeing a greater number of patients safely. So you can almost maintain your same patient complement in terms of the number of patients you see, because the patient calls can be done at any time. They can be done later, nights or weekends, whenever people decide to arrange it. You can then also have an enhanced image explanation for the patient, because the images are shared directly on the patient's screen in high res. The patient and the doctor can together look at it on their own screen and show all the details. The patients can then ask questions without the experience of feeling a rushed clinic environment. So in summary, COVID created many challenges for us, but we've adjusted and are poised to thrive as we move into the next phase. Thank you.